Yeah. So now we go to TAPS. TAPSE, I think you have shown in the previous
No,
question.
sure.
Okay,
But
let's do the TAPSE.
Okay.
We're looking at RV systolic function. RV diastolic function is still
yeah.
in research.
As I told you that I still use M mode for this purpose.
Yes.
And you can actually from the base you can go right inner edge to inner edge, whichever way you want to take it, or outer edge to outer edge. Yeah.
Yeah.
That is all
Just
right. And
go up. The cutoff is 1.7.
Yeah, this is
Yeah,
normal.
this is pretty good.
But remember, if the patient has atrial fibrillation, you should measure multiple cycles and average it. But it looks all right. 21 millimeter is okay.
Then we go to RV S prime. Anything more than 9.5 is pretty good.
So this is correlating with TAPSE. This is about 11 or about 11.5, which is okay.
Please don't measure the first one because that is isovolumic contraction wave.
Okay, so it's a patient actually in sinus rhythm.
Sinus. Now it is.
And occasionally there were ectopic. That was confusing us.
Right.
But
Yeah.
Because this spectrum is wide, so where exactly should we measure? Because
Yeah. Can you show it back? Can you get it back again?
same
Same
recorded
image.
picture.
31 image.
Recorded picture.
Okay.
Image 31, please. Recorded. Yeah, sir, you have a pointer.
Yeah. So you are saying where we should measure, here or here? You are measuring at the tip,
At the
right?
tip.
At the only thing is measure the chin, not the beard. So what you have to do is go down slightly on the gain and measure here. That's the best way. So you won't make a mistake. That is at the tip. And this, of course, isovolume contraction phase. This actually correlates with RV contractility independent of the load. You should measure its acceleration time. People have done a lot of studies, but we clinically don't use it that often. But one thing is certain that so long as you have big A wave, the RA function is normal. That is what all we can say. RA function is normal. This and you should mention about this.
Can
थोड़ा
you
सा
brightness बढ़ा दो? Can you
थोड़ा बढ़ाओ brightness.
increase the brightness?
ज़्यादा ही वो हो गया. That's all. This is what it is. And these are biphasic isovolume isovolume phases, isovolume relaxation.
what happens is sometimes if we increase the gain or decrease the gain, the values change a lot. So that's exactly.
What Dr. Mohan is trying to tell is you have to visualize the gains and
But
take 3
check
or
the
4
modal,
waves.
check the modal
Modal
velocity.
velocity.
Modal
Modal
velocity is a fairly good idea. In fact, this may not. I probably might take slightly lower down, but instead of 11.4, it may be 11.2.
Doesn't
Doesn't
matter.
make much
Doesn't
of a
matter.
difference. But whatever you do, you should have a consistent method of doing.
I think your lab should be consistent with that. That's the point. Okay, let's go to strain. We'll finish off the RV. So the RV strain analysis, as Sir was telling, they have now dedicated software for LA, RV, and LV. If you don't have it, you can still use the software of LV because we have been doing we have been fooling. So LV software can be used for RV, but for LV can you use for LA? The answer is no, because LA is a very thin wall structure and you may have some variations. So for the strain analysis, the septum is now considered as a part of the LA, of the part of the LV. So what they are doing is they are tracking the longitudinal fibers of RV, which are the lateral fibers, and you get the lateral velocities. So that is minus 38, minus 32, and minus 22. You can average it, and you are getting a value of minus 28. That is a free wall strain. It also gives you a global strain, understanding that the septum is a part of LV. So there are a lot of work which has taken up both the values, but preferably we and the guidelines recommend now lateral strain to be lateral wall strain. Cutoff is around minus 20.
This
Yeah,
is all
anything
right.
in-
I think the overall you should make a note of all the parameters, and based upon all the parameters, you should write that the RV systolic function is normal.
Yeah.
No single parameter is good enough, that you have to remember, and there are caveats for each of the method. More so when you are not seeing the RV properly. But nevertheless, overall we'll say RV function normal. For research purpose, will be very stringent.
Yeah.
We will actually have a definite protocol, we'll have a core lab, we'll have trained people, trained in a definite way, and same method should be used before and after intervention.
So is everybody doing this thing? Yeah, question. Do you do MAPC routinely?
No, we don't do
We
MAPC
don't do
routinely.
MAPC routinely, but Critical Care Society is doing MAPC routinely in ventilated patients. So they are now suggesting that we should do MAPC because I was talking to are there critical care guys over here? Okay. So we have better indices. We have LV strain. We have S prime tissue Doppler, which are not that angle dependent. I mean, they're not Doppler dependent. So
The
and the core.
problem with MAPSA will continue to be that the left ventricle not only moves longitudinally, it actually rotates on its axis and it translates. Also, it rocks.
Rocking.
Rocking, and all these things create very different values for me. A lot of people actually do not even rely more on TAPSE. Can we now do mitral valve?
Yeah. So they wanted chamber, so I will finish off LA there. So one question for all of you. You all are doing RV, TAPSE, RVS prime regularly. Yeah. I have problems. So let me give a situation. COPD, corpulmonale, those kind of patients. The TAPSE is 1.8, but the RVS prime comes to 9.2, and RV lateral wall strain is minus 17. What do I do? So I will repeat. TAPSE is, rather it is the other way. TAPSE is 18, which is slightly more than normal. RVS prime is 9.2, and RV free wall strain is minus 17.
So early stage of RV dysfunction, the TAPSE will be compensating.
Why?
Yeah,
so?
but
Why?
TAPSE,
Longitudinal motion.
Anything more you can think of? I mean, do you encounter this kind of problems? So what do you do with that? I can answer. I'm just asking. What do you do it?
but
So, I don't do fact.
But you know what? Whenever there is an increase in volume, the TAPSE will increase.
Yes.
Whenever there is increase in RV volume, TAPSE will increase despite RV dysfunction.
The best.
So you need to understand the dichotomy between the
So
two.
mention everything, and it is earlier RV dysfunction. Okay, so we go to LA quickly. So LA needs 2D measurement in parasternal long axis view. Then you do the LA volume index, which is 0.85 into A1 into A2 divided by smaller L. Everybody is aware of that? You want us to show it? Machine is aware. Are you aware of it?
So,
Can you show? Okay. So we'll do 4-chamber view, LA focus
Dr.
view.
Madhu, record 4-chamber
Four-
and 2-chamber,
two-chamber.
and then
Let's-
we'll do offline.
Offline
LA
quickly.
volume.
Let's do quickly that. So the machine knows the formula. You should know the formula. It is 0.85 into area 1 in 4-chamber view, area 2 in 2-chamber view, divided by the smaller L, and we index it to body surface area. So you take an LA focus view. Let's quickly do it, and we start from one annulus.
And there is a catch point in that.
Yeah, I'm coming to that.
Difference should be less than 10%.
Yes. So we are coming. I'm coming to that. You are correct. Yeah, just freeze it.
No, she's trying to take, I think, 2-chamber view.
Okay.
It's MS patient, no? It is coming. What do you want?
Yeah, I think LA volume.
2-chamber.
2 per chamber. Just
You
trace
got
it.
a 2-chamber? You got a 2-chamber view, I think.
Yeah. Yes.
We have both.
So let us now do the LA volume.
LA volume
using both
index.
4 and 2-chamber view.
Just do it.
LA
Let's do it
volume.
quickly. Yeah.
Biplane LA volume. See on the right side, there will be a figure called LA volume.
LA volume index. Yeah.
Yeah.
Okay.
होएगा नहीं ना?
You start from one annulus.
Height, weight mention.
exclude the left atrial appendage if at all you see it. Okay. Click,
कट कर दो
Click.
click, double click.
one more time. ओहो नहीं
Okay.
This we got area only.
That's
Just a minute.
A1,
Just a
fine. 23, and let's take a 2-chamber area. So, are you all doing LA volume index? How many of you are not doing it?
Let us do 2-chamber now.
You're not doing it. Okay. So,
Two-chamber,
request is
okay.
please stop doing.
37.
Yeah,
Frame 37.
yeah. Please stop doing LA by M mode
volume?
and please
Sorry.
involve because it has prognosticated importance.
Okay. No. Okay.
here somewhere.
Fine.
Yeah, yeah.
You can do.
No. So recommendation wise, sir, the split screen or the what is that? The 3D image gives you together. So what is it called? Explain. We should not use explain for LA volume index. I'm just trying to tell you. Yeah.
Set.
Okay.
Okay. Fine. Let's go ahead. Yeah.
Now you can Now you can take LA length
LA
from the
length
2-chamber.
from here, 2-chamber.
Because 2-chamber is a smaller.
Smaller. Take it.
Yeah.
Pull it down. Yeah. Go to the roof. Yeah. So it's around 4.7.
So we got the LA volume 82.5.
82 and index it to body surface. He must be what? 1 point. He's a thin guy. 1.5, 1.6, 6. Let's say. So it is 82 divided by. So it is around 50, 60. Anything more than 34 is bigger LA volume index. Okay. This is the case of mitral stenosis. You don't have diastolic mitral stenosis, but just to show LA volume index, we are just showing it to you. Correct?
Chalo, Dr.
Any
Madhu.
questions?
Dimension here in 4-chamber view.
You can measure. You can give AP view, mediolateral views. It actually has a rough idea.
Yes, sir.
So you have a mediolateral AP. Mediolateral is actually again should not exceed 4, and the what you call as superior-inferior should not exceed 5. That is roughly 5 and 4. But then there are no hard and fast rules that it can't be 5.2. Normally, if you find, I see from the annulus to the roof of the LA, it is 6 centimeter LA is enlarged. The mediolateral from septum to the lateral wall, I see more than 4, it is enlarged. But that is rough. The reason is there is a ellipsoid method to get LA volume also. You can get what you call three diameter way of getting the LA volume, which is fairly okay. It's not too much. But you know why we are talking? You and me have to speak the same language. How can we speak the same language? Use the guidelines, a definite set of rules. Rule says that use this Simpson's method. Let us do the two. You remember the LA volume earlier till 2006, 2007. They used to say use biplane area length method. And then they moved on last 6-7 years, they said 8-10 years, use biplane Simpson's method for LA volume, and now we are using Simpson's method.
So in your old Philips I-33, remember those actually very there, and they were promoting those things earlier in 6 to 8 to 10 actually that time.
So these things will see there is not much of a difference from research purpose. Very different. The point is you and me should be speaking the same language. How do we do that? If you do only in 2-chamber view LA volume and I do in 4-chamber, they will be very different. I do biplane, you do monoplane, they will be different. So we need to actually, and if you do monoplane for whatever reason, then you write, I am reporting LA volume based upon single plane, which is fair. You didn't have time, but you are telling overall LA volume is increased. This is one of the parameters for diastolic.
Yeah, so we are going to biplane Simpson quickly. So for that, so always LVEF should be spoken by biplane Simpson. There is no other way. Of course, 3D is there. For 2D, don't use Decoy's formula. Don't use M mode. Please, please, please. So once you go out of this conference from Monday, there should be no M mode for Decoy's formula for LV. Right, sir?
Yeah.
We should know that we should not be doing it. So what she has done is she has acquired a 4-chamber view and a 2-chamber view where it is a LV view where the LA is small. So there is no minimal LA. So she is now focusing only on LV. That's the way you acquire. This is a fantastic
This is
image.
good. No, that two chamber was good, Dr. Manu.
cycle
Yeah.
हो रहा है ना.
This is pretty good.
That is good. Let's do it. Ashish, let's
do it.
Yeah. So LV EF is nothing but end diastolic volume minus end systolic volume divided by end diastolic volume into 100. So there are automated softwares. You can also do manually. Oh, let's go to LV biplane.
Volumetry, Dr.
पहले
Manu.
volume का डालते हैं ना. Okay.
थोड़ा सा वो है.
Yeah.
That's the point. You said we are not going to do T calls, but we are supposed to use N mode for LV mass and
No, not LV mass also, no longer.
So it is a very good question. Should we use M mode for LV size, for EF, for LV mass? The answer is no. Please don't use it. It is by 2D measurements, not by M mode. So there are problems with M mode. We can talk because of the angle of cutting. It has to be 90 degrees, and there are a lot of variation. How do you get it? So this is LV ejection fraction by biplane Simpson. So you have to be inside in the just inside the endocardium. Any questions till now? Everybody has an automated machine, or do you have a manual machine? Everybody has a manual machine?
After doing the manual also.
No,
I will do
they
the
want
manual also.
manual tracing. एक बार कर डालते ना, I mean. सब automated BMW नहीं चला रहे हैं. I think we still have. Okay, let's try to trace it manually. Okay, that's fine. So end diastole is the tip of R wave. Okay, you get the end diastolic frame, or you can do manually. Okay, that's fine.
let's do
That's
that.
pretty good. Start from 1. Identify the LV end diastolic apical and trace it. No, the other way. Go up.
नहीं नहीं अच्छा
Yeah.
वो किया तुमने. मेरे को लगा अभी भी स्ट्रेन कर रहा था.
By the time she's tracing, any questions here?
that we are talking about automated machines. Most of us are not using ECG gating, and that is where problem.
So there are everybody has to have an ECG gating. I know it is very cumbersome, very expensive. Not at all. Okay. What I am trying to tell you is that I'm not going to speak in the mic. I put 3 ECG leads and use it on 10 patients. But I put it. It is very important. So this is the off-label thing. If you want to save money, that is one thing. Second, the usage of jelly on the probe should be very minimal because it slips.
Yeah, but I think you should buy the electrodes cheaper and use it. I never use it second time.
See, it's
Not
mic
even
में
in
बोला
my hospital, not in the clinic.
So-
no way.
So
No
if
way,
so the point is, please use ECG. And-
I think the moment you start, ECG has to be put in. Blood pressure should be mentioned left upper corner, and saturation should be mentioned left upper corner.
Correct.
This is what I would say. Why saturation should be mentioned? Because there are a lot of situations where saturation changes and saturation has a meaning. Once you have done saturation, you know what am I looking for? What am I trying to look for? For example, you have a patient with hepatopulmonary syndrome. Somebody has sent you a case of HFpEF, and this may be high output state because of liver disease, which 25% of the liver disease people have HFpEF and hepatopulmonary syndrome. You don't have saturation, you won't make a correct diagnosis.
Yeah, so she has done the modified Simpson, 58%. Okay, how much time did she take? No, she has done biplane, both the planes, I think. She has.
No, so far she has done four chambers.
Oh, it's only 4 chamber.
So let us do the.
फोर चैम्बर
chamber.
दिखा दो ना हमने तो किया.
So let me ask all of you, anytime if you do, I mean, I don't know whether they are doing biplane, do you get ejection fraction 75, 70% anytime? In your lifetime, did you get? What do you do? Do you report 75% a year? No? Why not?
ये नहीं है ना सही point.
75-80%. It is always there, 75-80% in hypercontract tachycardia or something like that. So,
So there is,
Absolutely.
yeah, so
If
you
there
are
is-
right. So there is a, Dr. Mohan, I would like to have your thoughts.
Supernormal ejection
Supernormal
fraction
EF.
is high. Actually, it's not a good thing.
It is not a good
The,
thing.
the ejection fraction relation mortality is
U-shaped.
U-shaped.
Yeah.
So you die on this side, you die on this side. You better stay between 60 and 70, more like that.
Yeah, whatever is there, do it again, do it 3 times. If it is consistently coming 70%, report it.
And Barry Burlock has mentioned a HFpEF is supernormal ejection fraction, which has a, no, there is a definite term. HFpEF means HF, SNEF, supernormal ejection fraction. And these people, there is a definite phenotype described. These are small ventricles, markedly thickened, and very prone to develop atrial fibrillation. Yeah, and markedly
Yeah, so they have
symptomatic.
it is problematic.
We're absolutely all right at rest and markedly symptomatic, 5-step, can't go to bathroom and you don't know what to do. You know, surprising, you can't do what to do. You don't know what to do. In fact, these are the people, if the transplant was a way, one could do it, in fact. Small ventricles, go to the bathroom, they're huffing and puffing. There's no drug which works. None of the drug works. All these SGL2 inhibitor, ARNI don't work in those.
Yeah. So there's an entity of HFpEF. That's what I wanted to ask. Yeah. So they are tracing the two-chamber view. I think let's do quickly and let's
You
go
of
to
course
mitral
know
valve.
that the volumes are underestimated by
Perfect.
2D. The volumes are better with 3D, but even 3D underestimates the volumes by
That's fine,
cardiac
that's fine.
MRI. The reason is all these trabeculations which are full of volume, you are missing it. So the best way is of course shoot contrast and do ejection fraction. If ejection fraction that important. With contrast, you get volumes which are as good as 3D, probably as good as cardiac MRI. You still underestimate, but the bias is less. So what we do quite often, me and Dr. Madhu, we shoot contrast in everybody where ejection fraction is critical.
Let's
Critical means you want to decide whether ICD or CRT should be given, or has the patient is showing improvement, or we are part of study. We'll always shoot sono-view. We will never report ejection fraction like this. This has a variation which is
do a regular
huge.
one and then right back.
You could report 50%, I could report 60%. This is it. But if you trace with the endocardial border comes so beautifully with contrast, there is no chance of making a mistake. There also foreshortening can still occur. So you should avoid foreshortening, but at least if you have not avoided foreshortening, then the estimation of volumes and ejection fraction is correct.
Shantanu, only one chamber is left, I think, RA.
I think
You have covered all the.
Yeah, I think let's not do RA because I think I will. I mean, we can always do it, but it is still in research thing. We can spend more time on the valve. I think we have 15 minutes. So let's go to the mitral valve. So the there was a guideline statement which came from the American ASE. Dr. Pandian is the first author, and myself and Dr. Mohan were a part of it. We had the privilege of contributing. So the guidelines have changed a little bit in mitral stenosis, and I think we should emphasize. So parasternal long axis view showed us that this is a rheumatic mitral valve. So we have the parasternal short axis view for the mitral valve area. Did you save it? So
We have saved it.
yeah, so the normal mitral valve area, normal, if we are all normal, is 4 to 6 centimeters square. Okay? Anything less than 4 or more than 2.5 is mild. Anything less than 1.5 is severe now. So there is nothing called less than 1. Anything less than 1.5 is severe. Anything between 1.5 to 2.5 is moderate. So let's do what is the short axis.
So we in general, actually, we Indians don't agree with that at all. Because most of our patients, actually mitral, they're doing pretty well. I do balloon mitral valvotomy, I get 1.5, 1.6 area. Don't call them severe mitral. Then what have I done? So I do a lot of BMV, even now, I get a mean average area 1.56, 1.6. There are females who are having a body surface of 1.4. Don't expect them to have 2. So all this is bullshit actually, ACCHA. The severe being less than 1.5.
वो ऐसे है ना
No, even otherwise, this grading by Rick Nishimura, basically of less than 1.5 being severe, more than 1 being progressive mitral stenosis, is not meant for that purpose actually. All they are saying is the patients are more likely to be symptomatic in case valve area less than 1.5. So let us call it severe. In a similar way, from our viewpoint, we remain same thing. We like to intervene if the area is less than 1 centimeter. Most of our patients symptomatic with less than 1 centimeter, 1 or less than 1 centimeter, and between 1 to 1.5 we individualize. I have a 13 years old girl, she has a 1.2 area, I'm happy, I'm not going to do anything. So I don't care for this thing. And I think even the ASC, this thing, these unfortunately came out because this was heavily weighted in favor of people who wanted to follow ACCHA, didn't want to annoy them. And we Indians didn't want to say too much about this thing. But the fact remains we don't care for that. We just don't worry about that. Should we write our own guidelines? Sure, we should write about mitral stenosis our own guidelines. But somebody has to take the lead. I am telling you, I have been doing balloon mitral valvotomy
Remove it and do a
independently since 94, nearly 30 years. And I have my average area, actually, I have published the same work a lot of times. LV volume, change in area, this and that, all kind of nonsense things. But my average area comes 1.6, which means about 40% of my patient will achieve an area of less than 1.5, which actually also means that am I calling that severe remaining severe? This is the point which we have to keep in mind. And their gradients fall down. If the gradient is still 7, 8, valve area 1.4, I'm happy.
But they do get some a good relief from symptoms.
Yeah, they get the symptom. And as far as the other part, the stress is concerned, there are no gold standard to say this much is the increase in the gradient that you should consider re-intervention or consider them symptomatic. I think that is a absolutely gray zone actually. PA pressure rising, or you can use it as one of the factors, but don't rely totally on it. And we actually try to use that any number actually more for support rather than actually as a guide that this is what it would be.
So the planimetry was done. It is surely severe mitral stenosis, but let's emphasize that we have the commissures here. Can you
Yes,
sir,
commissure.
point it? The anterolateral commissure is fused. Even the posteromedial commissures are fused. Both are fused.
I think she has done a pretty good
Very
job
good,
because
yeah,
we
yeah.
are right at the tip. But here at least I think we can use the biplane.
Yeah. Now
But,
let's use the biplane.
Yeah.
I would say she had done a good job because the thick curtain should always be anterior. So
Anterior.
long as there is thick curtain anterior, and you should measure in mid-diastole. There is another point. The guidelines recommend mid-diastole. So you record in mid-diastole. Yeah.
वो नहीं चल रहा ना पर अच्छा दिख रहा है
Okay.
That's
this
pretty
is
good.
fine. This is pretty much all right. This is pretty much all right. Yeah.
वो आ रहा है
Yeah. Yeah.
So commissure calcium needs to be graded 0, 1, 2 on both medial and lateral sides. So the maximum score can be 4, 2 on this side, 2 on that side, maximum 4, and the least can be 0. That correlates with the occurrence of mitral regurgitation than with anything else, because then you have a shear stress which is heterogeneously distributed. And Navesh Sutaria actually was the first person who actually gave that classification. There are at the moment about more than 20 different what you call it, scoring systems for mitral valve. I was yesterday trying to read 20 different scoring systems. Obviously, everybody thinks the other score system is insufficient, but I think by and large we use Igor Palacio system, you call it MGH, or Boston score system, or Wilkins score system, which actually correlates reasonably well with the outcome. Not for mitral regurgitation, but total overall outcome.
Yeah. I think this is a pretty good one.
Yeah, this will come 0.6, I think.
6. Yeah. It will be very tight. And we are at mid diastole. Yeah. So this is the commissural view. What is the next other commissural view we have? Can anybody tell me the other commissural view?
0.76, they have done a good job. 0.76, all right.
Yeah.
You can actually do a planimetry aortic valve. Just to show rheumatic, you should always do a planimetry aortic valve using the biplane method. But put the cursor at the tip and then do it.
टेढ़ा जा रहा है
So it is a apical two-chamber view. He is also the commissioner.
मैं ऐसे करती हूँ गुड वेरी गुड
Yeah.
Yeah, that's very good.
Very nice.
Pretty
Very
good.
nice.
And again in mid-systole, remember the word planimetry in mid-systole. 5 or so, 1.6. So we have right commissure, left commissure, and then a posterior commissure. On one side, yes. One side, yes. Let us.
That's pretty good, but
Yeah, it's okay. We'll accept this thing. Actually. By and large, we'll accept it. Okay, we can go slightly lower down. That commission is open, but it's okay. Just to show that you should do mid-Sicily.
You mean here?
Yeah, I think I thought I would have gone.
I'll do
into-
it again.
It's all right.
No, no, you are right. We can go.
But remember, aortic value is never exactly, at 90 degree to the aorta. And aorta itself is not 90 degrees. There are a lot of horizontal aorta and the horizontally placed aortic valve. So you have difficulty in getting the what you call as cross-section view, en-face view. But the AC, the guidelines do recommend that you should do planimetry of in 1.26. That's pretty. There's a probe actually. The matrix probe actually you can get biplane, you can get triplane, you can get 3 or 4D. It's a matrix probe. If you have a phased array probe, which is two-dimensional phased array probe, then you have to do separately. But this is a matrix probe. So what you do is you put a cursor. The two viewers, even 3 views can come. The 3 views will be at 60 degree apart, and these will be 90 degree apart. And of course, she's trying to look for actually mitral. There is a trace of mitral regurgitation. We ideally we should have quantified. We don't have time actually. We will probably try to cover it up in the rest of the meeting. CW, get the gradients. Yeah, pressure half time. Yeah, which is okay, Dr. Madhu. I think we get going with this
you're doing great.
third beat.
Third beat,
Let's do first or third beat.
measure.
First, थोड़ा वो कम करो ना.
Yeah, this is good. And again, you have to go to 100 mm per second speed.
Trace.
Let us
Yeah.
first
Yes.
get the gradient overall.
Auto trace.
And let's trace, no, it is not tracing correctly.
This-
You have gone in early part of Sicily, not tracing correctly.
I think I will do it manually.
Problem with artificial intelligence.
Yeah, Ashish is laughing.
This is MR trace.
Oh, this is Amar. Where is the?
Mitral valve trace.
Let's do it. I always prefer to go and do it here. No, trace it.
Modal velocity.
Yeah.
You should measure always.
So I did it with the left hand just fast. So it was around,
So-
mean was around 7, but a heart rate of 58.
Yeah.
So,
So I think anything more than 10
there is
mean.
a discrepancy in the area and.
Yeah, so no, there is no discrepancy.
There is, yeah.
So it is 10 mm and above mean at a heart rate of 60 to 80. So this can happen. You just give her some IV fluids, 100 ml, or make her directly walk. She'll be symptomatic.
But I just want, yeah, you are right actually. But this discrepancy is there. You know, the what we call a low gradient mitral stenosis
Yeah.
is there in almost 40% cases. Patricia Pellico wrote an article that was on calcific mitral stenosis, but in rheumatic heart disease also we see low grade mitral stenosis quite often, and the reason is the stroke volume is less. So I will tell you what would be the stroke volume of this lady. She has an 80 VTI. She has a stroke volume of 50. 50 divided by 80, that is what you are getting the area. Or let us say 55 divided by 80. You are getting about 0.7 as the area. So her stroke volume is less,
Low.
male or female?
Male.
Male. The stroke volume more like 55 ml.
50.
So low gradient mitral, diuretics is one cause. Aortic stenosis may be another cause. Itself, aortic stenosis may be another cause of this thing. But nevertheless, the effect remains. Slow heart rate is the third cause actually. So I always keep showing you an example. I was doing an echo of one patient. The valve area is 0.95. I'm getting gradient 16 and 10. Heart rate is actually 73. And I do a long study, patient doses off, the heart rate drops to 63. Now the gradients are 10 by 6. The valve area measured is 1.05, which is not too different, but the gradient fallen to exactly half.
हाँ लेके वही दिखा रहा है.
So the question is, if we remove the tissue harmonics now, will the thickness of the valve or the area of the valve change?
Yeah, it changes.
Yes,
a
it
little
changes.
bit because there is
By
there is a
point
trailing shadow.
20%.
In harmonics, there is a trailing shadow.
No, I think the recommendations are using harmonics now.
Harmonics.
Yeah, so and you can always do it, but it goes down by 20%. So we are trying to look at the aortic valve because one of the causes of the low flow MS can be aortic valve problem, aortic stenosis. Yeah, yep.
So the patient does have moderate aortic stenosis. This will be the cause of the low gradient. Besides the slower heart rate, lower stroke,
Yeah.
diuretics is another issue. And of course, we should not forget tricuspid regurgitation can be another issue.
Yeah, just put a. There is a
Mild aortic regurgitation there, vena contracta looks like 3 millimeter, but it could be little more, could be.
just put Doppler flow. Yeah.
We do have some gradients across this. So mitral, actually the pressure half time of the AR probably will be around 500. It will tell you that this is mild mitral regurgitation.
Yeah.
Less than 250, severe 250 to 500, moderate more than 500. Let us take that way. Okay, it comes to how
1,000,
much?
something around 1,000. It's more than 500.
Yeah,
it is
more
mild.
than 500. All right.
Okay, can
And there is some gradient. But remember, the mitral stenosis will reduce the gradient of aortic valve, and aortic will reduce the gradient of mitral.
so
these
mean is around 15.
yeah.
This is evaluated low, less because of MS.
Yeah, but you know, we were discussing saying the aortic VTI is 50, and we had calculated the stroke volume 55, 56. 55 divided by 50, you are still getting area 1.1, 1.2 centimeter, which is pretty much fitting with everything.
Everything. Are you guys getting what did he say? How did he get the stroke volume?
No, I went indirectly. See, the patient had an aortic mitral valve area of 0.7, and the VTI on the mitral valve was 80. So the valve area is equal to stroke volume divided by VTI. So
Stroke volume will be this into this.
area multiplied by VTI, I got stroke volume. Stroke volume comes to
55,
56 ml. 56 ml divided by 50, I get by
1.1.
1.13, 1.12, 1.13 of the aortic valve area.
Which you also
is
got
exactly
in aortic.
what we are getting.
You are also getting in planimetry, something
By
like
same
that.
method, 1.1, 1.2 we
Yeah.
are getting.
So do we use dimensionless index? This was the question. Somebody mentioned. Yeah. Do we do dimensionless? Okay.
So LVOT, Dr.
VTI,
Madhu,
LVOT VTI divided by aortic valve VTI. It is also used.
but
It is
native valve
also. It is also used for native valve. 0.25, less than 0.25.
Diameter लेना है.
Yeah,
वो तो
that's
लेना
that's.
पड़ेगा.
No, no,
Put a pulse
LVOT
wave.
सिर्फ VTI,
Put a pulse wave.
this has to be 5 to
Pulse
10
wave.
millimeter
Correct.
approximate. Yeah, very good.
Very nice.
चलो,
Freeze.
ठीक है.
Trace. Ashish goes for auto trace always.
Auto.
Correct.
25.
No.
थोड़ा सा अंदर करना
No,
पड़ेगा.
this is not doing this is not doing a modal. It's not modal. It is taking the beard also in picture.
So Ashish is changing his beard. I think shaving his beard. It's around 20.
Okay, we will accept 20.
And let's have aortic valve
So
VTI.
that was 50.
That was on CW. You want to take that or you want to have a
No,
PW?
that 20 divided by 50.
But would you like to have PW at aortic valve?
No, they're all right.
It will be all right. Okay, 20 divided by 50 is
0.4.
0.4. So it
the-
is moderate.
Yeah, but-
If it is 0.25, then it is purely severe.
But you know what?
You are dealing with mitral stenosis.
Aortic valve gradient we have taken only in apical view. You need to take suprasternal right. You have to get the maximum velocity. So we
TBI, how much is it? Where is it?
0.39.
Okay,
We
correct,
saying
correct.
we
Point-
said about
point
0.4.
three. But I think I will label it as severe MS and severe AS.
No, MS is not severe, the AS is not severe, is more moderate. Dr. Madhu, एक काम कर सकते हैं, and that is, can you try to get gradient of the aortic valve better, इधर उधर करके?
Yeah, but sir, is not the MS flow affecting the aortic valve flow?
No, but we have measured the aortic valve area,
Oh.
planimeter. That's 1.2. That's why I'm saying it is.
That's
for-
pretty
this is
robust,
for-
yeah.
Yeah, it will come same 1.1.
Say 1.2, 1.1, 1.2. So it becomes more. Yeah.
I'll do it manually.
Right parasternal
Suppression
also.
कर लो. But I think it is all right. It's
Yeah.
same actually. This is a classic example of low gradient, low flow mitral stenosis, low gradient, low flow aortic stenosis. Not
With-
severe, but moderate.
With preserved ejection fraction.
She will need a DVR, or he will need a DVR.
I think over a period. Yes.
Mitral valve we definitely can. I will open the mitral valve and I will actually look and follow aortic valve conservatively. Yeah. To over digress probably. Yeah. Over
Yeah.
digress.
What is the age of the patient?
Age.
Okay.
कितने साल के?
60. Still, I think,
I
sir, will
actually,
open
if
up.
you leave it to me, I will open the mitral valve
60, 60.
and then follow the aortic valve and see how it behaves.
And watch the aortic valve.
Yeah, I'll watch the aortic valve closely. The left ventricle size is only 4.4. I'm not. There's no LVH, so I'm not worried about aortic valve that much.
So small clarity about some other deformity and this one actually. Just can you show again about once you go for the BMB? So have we get clearance actually? We should go for the BMB or not?
First
Some-
thing, subvalvular pathology has to be seen only in parasternal long axis because you get the structure exactly perpendicular to your insonifying beam. You do it in 4-chamber or 2-chamber, you will make a mistake. A lot of people do in 2-chamber where subvalvular pathology looks terrible. That's not the way to look at it. Parasternal long axis view, the chords are directly perpendicular, insonifying being this. This is the way to do it. Dr. Madhu, show the last parasternal long axis view and we are out. Okay. And stop here. So, and these chords are all right. So these chords are all right. So this is not severe. We can say moderate. You could quantify it between 2 to 4. These chords are all right. These chords are all. These are fused chords. These chords they are looking thicker. This is because the gain is more and this is harmonics. So if you're in fundamental, these chords, this part will look normal. Yeah, these chords will look normal.
This is a pliable mitral valve. You can open it up.
Say about commissioners and the short is just small last.
Let's have
Commissional.
commissional view in apical
Yeah.
2-chamber.
Low gradient, low flow.
Apical 2-chamber.
2-chamber is a commissional view.
Yeah.
So the stroke volume should increase to some extent. And I think gradient will slightly increase, but then from 13 mean gradient, they may become 16, 17, they will be in that category of mild to moderate. And I would like to follow this aortic valve for a long time, maybe for a long time patient means all right. And subsequently, if we are required, it can always be done. Doing a DVR or, see the point is once they open up, nobody does OMC nowadays. They straight away.
So this is the
mitral
commissional
valve.
view. Yeah, apical 2-chamber commissures are there.
So you have
Apply this in the short axis.
medial and lateral.
Lateral commissions.
In the short axis.
Short axis is at the mitral valve level wherever you are doing planimetry. Yeah. So I think we'll have to end. Okay, we're ending. I think Dr. Madhu did a very good job. Very nice.